Hello. This is a complex subject about which everybody has some knowledge, either from peripheral readings or structured learning. And this is why I thought that I would probably summarize into a straightforward, easy to understand subject based on the way medical students learn certain subjects such as um, cardiology, neurology, and so on. So if we know that kind of an understanding, I think we would probably be understanding better the newly emerging changes in guidelines and so on. I can't claim to be more knowledgeable than an average person as far as my awareness of psychosis and schizophrenia is concerned. But when you go through this webinar, you probably will begin to understand how symptoms are shared between various components of schizophrenia and how there is a mix and match between varieties of psychosis and schizophrenia as such. And you will then understand, using common sense and practical skill and experience, how to apply the knowledge in the patient care. So we will now look at the updated PowerPoint slide that I have actually prepared for this topic. The presentation is based on updated information, which began with the NICE guidelines in 2014, unamended practically last year, and then, of course, on various textbooks of psychiatry and updates on research journals, and also on what the understanding of schizophrenia is under the WHO. And of course, various new researchers have come in via research publications, and they are listed here. And so we now move on to the next stage. So in respect of defining what exactly psychosis is, this is of a several kind in its nature and is related to stresses in life, stresses at work, and also some sort of environmental pollution. And we'll come to that in the relevant sections. Sometimes when a patient is exposed to various injurious chemicals through respiration, water supply, and medication, then obviously symptoms of psychosis are seen often. There is a group of psychosis and schizophrenia related illnesses, popularly termed as bipolar disorder and psychotic depressions. And it's much easier for me to say that these are all same conditions using some aspects of one and some aspects of the other group. So therefore they are interrelated. But having said that, there is a pattern that you can see commonly in certain groups of psychotic conditions. So one can safely understand that schizophrenia per se follows a particular course, and the illnesses connected in psychosis to schizophrenia affect the patient's behavior, how he reacts, how he speaks, how he acts physically, distort the patient's thoughts. So the patient may be imagining non-existent things and maybe misunderstanding things which are meant differently. And sometimes the patient has mood disorder, which is usually sadness, depression, but can have elevation of mood as well in different proportions. So what I'm trying to say is you cannot strictly say schizophrenia must have these symptoms and psychotic depression must have these other symptoms. There is an interplay, and that makes it more difficult to diagnose, but also to treat and manage and follow up. There is, of course, a subtle difference. So when you have grouping of patterns of symptoms and signs, you call them by a group title, such as schizophrenia. And then there is some commonality, but otherwise there is a sharing of some symptoms and some features, and the same applies to their treatments. And some medications work both for psychosis and schizophrenia, but they do not particularly work for a variety of psychosis, which is bipolar manic phase. And so the story relates to antibiotics, that obviously um, some antibiotics work for a large group of bacteria and some do not. And so in terms of understanding, without confusing the matter further, I would say that the commonest example of psychotic disorder is schizophrenia. So therefore, in an unqualified manner, if I mention about schizophrenia, that's exactly what I mean. So schizophrenia, translated as a split mind in German, is the commonest psychotic condition. And as I had hinted earlier, that there is a group of symptoms which is not strictly always, but often associated with schizophrenia. And that is disorders of perception. That means a patient perceives by hearing, feeling, and by imagining and analyzing something which may be unreal, or that a person may misunderstand what is told to him or shown to him differently. The second aspect is the patient has distortion of belief. And so this leads to various kinds of disorders. In respect of belief, one excludes religious faith. And having said that, the distortion of belief could be that the door of the house was open, and therefore this actually means that that person is king of Spain. So therefore people analyze their thoughts in an abnormal way, and there is also a problem with being suspicious. And so the other aspect that is very often seen is a disorder of expression that relates to gestures, speech, how to deal with people in response to a certain cue or hint or behavior. So these issues are often seen together in some proportions with the schizophrenia. So that is distortion of perception, belief, disturbance of thought, and interpretation and analysis of thought being persecutory in nature, and expression, which is disturbed speech, losing words, or acting unusually oddly. We will clarify more of these in a minute. First, let us look at the number of people that are suffering from in the UK and the world. So incidence being the strict number. And so if a person has some features of schizophrenia, some feature of manic depressive psychosis, then where do you categorize these? Perhaps you could join them together as psychosis and say these many people are currently or have suffered from schizophrenia or psychosis in a period of time in the UK, but it's very difficult when symptoms are shared and accordingly diagnosis becomes confused. Prevalence is easier to measure, and in the UK particularly, as of 2019, the prevalence was 0.5%. And this was in relation to adult population, adult being someone over the age of 16. So current information suggests that for an adult over 16, there is a lifetime risk at some stage of developing schizophrenia by 1%. Schizophrenia alone usually costs 2.8% of NHS budget, which runs into several billions. Because some aspects of features are common in different types of psychotic illnesses and schizophrenia, it is not easily possible to give an exact number in terms of incidence. If the accepted features and disorders are common in the rest of the world in diagnosing schizophrenia, then the prevalence has risen by 5 times. And if you are talking about curtailed strict features of schizophrenia, beg your pardon, if you're talking about curtailed features of psychosis, then the prevalence is 15 times more than was statistically presumed to be in 2014. So in summary, incidence has risen, but it is difficult to be accurate. Prevalence has definitely increased, and that the lifetime risk of an adult person suffering from schizophrenia is 1%. We should now look at features and factors which produce schizophrenia and the risk factors which are identified. So, the risk factors include features of cortical atrophy in the frontal and midbrain region, similar to what is seen in aging. And when there is cortical atrophy and loss of substance, then there is correspondingly enlargement and engorgement of the lateral ventricles. So someone who is very elderly with cortical atrophy is much more likely to develop this condition. Schizophrenia is common between 16 and 40 years of age, and there is no preference of gender. So most studies suggest that male involvement is as frequent as female, but some research studies suggest that female have a slightly more early onset. There is definitely a genetic reason which is ill understood. If one twin has schizophrenia, the other is likely to have 85% likelihood of developing schizophrenia as well. If a single parent has schizophrenia, then offspring is likely to have more than 7.5 times increased incidence and development of schizophrenia. South Asians and Blacks have 2.5 times more risk than Caucasians. City dwellers have a higher incidence than in people who live in farmland and also in rural areas by 2.4 times. Most of these cannot be fully attributed to genes, race, economy, and family history, but these are the accepted risk factors. Poverty is an important factor in development of both psychosis as well as schizophrenia. But it is said that when there are economic migrants who reach a wealthier Western country, their incidence, early development, and production of schizophrenia and psychosis remains as high as it would have been had they been living under their accepted conditions and environments in a third world country. Schizophrenia is more commonly seen when there are safeguarding issues in adults or when the same patient had had safeguarding problems in childhood, and the incidence is increased by 2.8 times, and this is a contributory factor which is well recognized. Adverse life events such as death of a sibling early in life or a parent's death have a negative contribution in the development of schizophrenia, and such people have been known to have schizophrenia 3.2 times more. 40% of cannabis users have features of psychosis and in particular schizophrenia. But other drugs other than cannabis may have twice as much in response to producing schizophrenia. Non-cannabis agents, substances, usually give a longer suffering and shorter remission. There are some therapeutic substances such as corticosteroid or stimulant medication, which is given for ADHD and so on, which can induce both psychosis as well as schizophrenia. Young or older parenthood is also associated as a risk factor for schizophrenia. Intrauterine exposure to toxoplasma and deficiencies of folic acid are also related to a higher incidence and earlier onset of schizophrenia. The prognostic outcome with treatment is far better in developed countries than in the underdeveloped countries. So, how do we describe features or symptoms and signs of schizophrenia? People with schizophrenia may have acute symptoms or chronic symptoms. Acute symptoms are called positive symptoms, but they may be variable mixture of other psychotic features. And Kurt Schneider has called these as first-rank symptoms. So positive symptoms are first-rank symptoms. Chronic symptoms are largely symptoms of negativity, such as sustained depression, and we'll describe more what is meant by that. So the first-rank symptoms, acute symptoms. So there are certain examples, such as hallucination. This is when there is no objective, realistic trigger, such as a patient says that there is a person standing behind his back, when that is not the case, but the patient believes that there is someone behind the back. So it is unreal perception. There could be perception of hearing things which are not real, such as there is a person who is talking behind the patient, which the patient can hear, and is often making a running commentary in a derogatory manner as what the patient is doing. This auditory hallucination can lead the person to obey certain commands. Also, in respect of severity, when a patient perceives that there are two people behind his back which are not really present, and that one is talking to the other person about this particular patient, then that is a stronger marker. And it is referred to as a variety of repetitive slangs and insults called echodilapancy. In addition to, or as an alternative to auditory hallucinations, there could be somatic sensory hallucinations, such as a person can see something which others can't, or I smell which others don't say is present, or taste something unexpected and unreal, or something touching the patient by way of somatic sensations. Then the other strong feature of schizophrenia is delusion. That means some stimulus is present, but the patient understands it differently. And this is something which is more often seen in schizophrenia. So if a person waves a greeting and that person is passing by, casually walking, going past the patient feels that he's actually insulting this patient in some particular demeaning manner. So certain activities or events are misunderstood, such as if there is a TV broadcast going on, reading the weather report, it can be misperceived through delusion by the patient in thinking that the newscaster is actually preventing the patient from going out because the heavy rain that he has said would come in will also lead to additional problems such as lightning strike and all of that. Another common feature of schizophrenia is delusion of thoughts. And that means that the patient feels that whatever he is thinking is understood and transmitted to another person, or the other person is actually commanding the patient's activities. And so the patient feels that this new thought has been inserted by another person, or that if the patient is making a plan for a personal reason, that is revealed to the other person. And sometimes the patient feels that the imaginary person behind him or around him is actually advertising bad things about the patient. An important aspect of delusion is suspicion and persecution, in the way that the patient would say, I am a very important person and secret agencies are following me, or there is a curtain drawn in a neighbor's window and the purpose is to put in a camera or a video to record the patient's activities. Another aspect is disorder of expression, which means behavior. So someone greets a patient with good morning, and the patient says it's an insult because there's nothing good in the morning, and therefore he feels that the well-intended greeting is actually a form of insult. Another aspect is erratic choice of words and moving away tangentially. So, as in a game of chess, the knight moves 2 steps forward and 1 step to the side. In the same way, a patient will start off a conversation and tangentially move away. Sometimes he comes back to the original subject, sometimes he doesn't. Then there is a kind of symptom called posturing. So a patient makes a gesture, say facially or through hand, and keeps it at that, even though there is no need to continue doing that. So these were acute and first-rank symptoms of schizophrenia, which are often seen. There is, on the other spectrum, the negative kind of symptom produced by schizophrenia, And this would be unlinked to antidepressant or side effects of antipsychotic medication. So they come inherently as features of schizophrenia. So there is affective blunting, so showing no facial or other response. Someone is explaining that there is a tragedy that has taken place and the person doesn't respond by appropriate facial and other gestures. Another feature is that the person speaks slowly and possibly takes much longer to say something, and often is unable to explain properly because they have forgotten the right words. They could be lack of drive, motivation, and feeling of purposelessness. And so a patient feels incomplete, unable, unworthy, and also incapable. As a result of such loss of sensitivity and normal activities which everyone takes in life, the patient goes into social withdrawal because he realizes that what he thinks and what he says is not approved of being right or dealt with properly, so there is something wrong with him. As it is, toileting, dressing, clothing, and grooming, these are neglected. And so often there is social withdrawal because the patient feels that he is unfit to be in that society. The diagnosis of schizophrenia needs to be made to set up a management plan. And the International Classification of Diseases in the 10th evolution has formulated that F20 is the broad diagnosis of schizophrenia. And since there are several kinds of schizophrenia presentation, they are coded as F20.1, F20.2, and so on. In order to make a read code or index diagnosis of schizophrenia, the IC10 criteria means that there should be, first of all, a 1 month history of one or more of these symptoms: hallucinatory voices, particularly third person, or thought disorder, such as thought insertion, thought withdrawal, thought broadcast, or delusion of control. That means a person doesn't have understanding of what gestures mean what, how to respond, and then there could be delusion regarding culture or religion, but these attributes cannot be explained fully. So the diagnosis is 1 month history of one or more of the symptoms that I have described in green. The same classification says that apart from the above mentioned factors, if there are 2 factors with a 1 month history of persistent hallucination of several weeks or months, breaks in trains of thought, such as night move speech, inventing new unrecognizable words, or posturing, or having apathy, anhedonia, or living in one's own world without getting involved with others around them. As long as these negative symptoms are not linked to classical depressive disorder or side effects of antipsychotic medication, or if there is significant change in the personality, a talkative person goes quiet and remains quiet and withdrawn, those kinds of things. So The diagnosis of schizophrenia, according to International Classification of Diseases, requires 1 month history of any of the two features which I have listed as yellow and have just explained. There are, of course, other psychotic disorders which have common symptoms to schizophrenia. One is schizoaffective disorder, when there is low mood or high mood, or also called bipolar disease, where there is manifest manic, aggressive, active symptoms, or there is withdrawn, severe depressed symptoms. Then there is drug-induced psychosis. So the substances such as cannabis, cocaine, heroin, LSD, or amphetamine-based substances can produce symptoms which are those of psychosis, are also noted every now and then. But the changes or the difference is that if there is cessation of such intake, then within a month, the patient improves and maybe achieve full remission from this psychotic drug-related problems. Sometimes in persistent delusional psychosis, where other features of psychosis are missing, if the symptoms of delusion persist for a very long time or become pervasive, that's a unique kind of psychotic disorder as well, which can't be classed under schizophrenia. So, what is the prognosis? As in pre-diabetes or reactionary hypertension, where someone has hypertensive levels in the presence of the doctor, but these subside at home. So there are well-recognized prodromal features which can start a few days or even as long as 18 months ago, but they come and go or remain. These are mild features. So when a person is in this prodromal phase, pre-schizophrenia case, then there could be emotional and behavioral changes, a manifest lack or avoidance of pleasure and hedonia, or there are disturbances of speech, slow speech, bradykinesia, and losing of memory. And also there are short-lived non-substance or drug-related psychotic changes which improve. So if these features are present in someone that can't be explained through appropriate other diagnoses or comorbidities, then one must, I suppose, think of prodromal phase of schizophrenia. Because this is the kind of condition which, if leads to intervention, improves by 80%. And such patients have 20% of such patients have remission, loss of symptoms for more than 5 years. A small percentage, such as 15%, are unhelped in the prodromal phase and remain with persistent symptoms. An indeterminate percentage show some improvement and then acute attacks with first-rank symptoms. So the prognosis is variable. The earlier it is treated, the better the outcome. And whereas it is difficult to say what the real prognosis in the UK under NHS is of diagnosed and treated or managed schizophrenia, it is easy to see that poor prognosis occurs with longer duration of untreated psychosis. This is due to patient having capacity and declining intervention, or where schizophrenia has developed very slowly and in a subtle way which is not identifiable easily. With regard to prognosis, poor prognosis is with male patients rather than female patients. And if there are primarily more negative symptoms of schizophrenia, that leads to poor prognosis. We have already mentioned the prevalence and the incidence, which has increased noticeably with positive family history. That applies to the prognosis as well. If a patient has been lacking in education or is exposed to poor socio-economical matters and has social isolation, their prognosis is probably worse. If there is a significant unrelated past psychiatric history, such as history of drug use in the past, such patients have poor prognosis with managing schizophrenia. If someone is addicted to a substance and does not give it up while suffering from classical schizophrenia, the prognosis is not good. What is the role of talking therapies or psychological intervention or psychosocial intervention? Cognitive behavior therapy of a specialized kind relating to schizophrenia requires experts which are not easily available in all mental health centers. Awareness and improvement of cognition is the key to improvement or stopping worsening. It is the lack of cognition which is what leads to hallucination, delusion, thought disorder, and speech disorder. An improvement of cognition is likely to improve the patient further. Simple counseling, supportive psychotherapy, and psychotherapy or counseling in relation to family therapy helps in boosting the management and recovery into remission. Psychoeducation leads to psychoanalysis, and this helps, but it's easier said than done, and it's very difficult to achieve because if the patient does not have cognition that they are ill, they will not go through a structured program, no matter how easily and quickly it is supplied. In relation to physical symptoms of schizophrenia, particularly with regard to negative symptoms, social skill training is helpful. Indulging in arts, music, understanding music is also helpful. These are all referred to as stimulation techniques. So, what pharmacological agents are used as antipsychotics? Joint Formulary Committee of 2020 based information suggests that there are two methods of administering medication. One is oral preparation, and the second is depot injections. Quite clearly, in a compliant patient, oral preparations are preferable. In a non-compliant patient who has no cognition and refuses to have periodic top-up injection or top-up treatment, depot injections are better. Antipsychotics work on the basis of interfering with dopaminergic and other transmitting neurotransmitter impact. So the earlier antipsychotic medications, which were called typical antipsychotics, are first generation antipsychotics. So they basically oppose the dopamine transmission, but they also interfere with acetylcholine neurotransmission, and that leads to extrapyramidal symptoms such as those of Parkinsonism. And the first generation antipsychotics also block histamine and 5-hydroxytryptamine, which is the other name for serotonin. And therefore, if the transmission of these neurotransmitters is blocked or slowed down or stopped, then obviously a patient sort of say has a different mental reaction. So it is the excess of these neurotransmitters, including dopamine, which results in acute symptoms of schizophrenia. And blockage of these through agents which are dopamine receptor antagonists are first generation antipsychotic, which have plenty of side effects. The second generation antipsychotics are called atypical. And this is because they block serotonin, which is 5-hydroxytryptamine, in addition to dopamine, but they selectively do not much block histamine, acetylcholine, and produce other side effects which are common with first generation antipsychotics. This is why second generation antipsychotics are more reliable. When one relates the outcome of treatment in respect of cognition, whether it is improved or whether the negative symptoms of schizophrenia have improved or not, then there is no evidence that second generation antipsychotics are better than first generation. In other words, overall, collectively, the outcome is better with second generation antipsychotics or the atypical antipsychotics, but not in a global sense. So, talking specifically about the side effects of antipsychotic, based on the above given research data, so the typical first generation antipsychotics have more side effects than second generation. And these are anticholinergic side effects leading to extrapyramidal symptoms, dryness of mouth and eyes, sicca and blurring of vision, interference with bladder mechanisms, so could be retention or constipation. So first generation antipsychotics have these common symptoms. The second generation antipsychotic basically deals with and blocks the dopamine. So it is associated as side effects with postural hypotension, and there are some varieties which I've listed, which produce more sort of vasovagal syncope. Some induce hypertension, such as aripiprazole, olanzapine, quetiapine, and risperidone. But as I've mentioned earlier, the risk of extrapyramidal symptoms and anticholinergic symptoms are reduced. A problem with second generation antipsychotic is that it lowers the seizure threshold, particularly with clozapine. And this is because seizures can be produced with sort of say lower triggers or lower level of triggers, whether it is flashing lights or sounds or a particular dose of the previously stable anti-epileptic medication. For this reason, and for metabolic symptoms such as those of diabetes, certain medication in this group of second generation, such as clozapine, is usually managed in the hospitals. So there are other side effects which are produced by all antipsychotics, whether first generation or second generation, such as dyslipidemia, and some medications in the antipsychotic group are more involved than others, and there's a list here. Hyperprolactinemia, which is also a possible side effect with any kind of antipsychotic. Increased risk of osteoporosis, sedation, or increase of the QT interval leading to cardiomyopathy, particularly with quetiapine, amisulpride, and also in the way of altering potassium level, which goes up. There is a thrombogenic effect with most antipsychotics, particularly with olanzapine and risperidone, particularly in the elderly, leading to stroke. Neuroleptic malignant syndrome is rare but can happen with any antipsychotic, particularly with changes in doses or addition of SSRI. So the features are similar to organ failures as in sepsis, and there will be some inflammatory markers such as creatinine kinase, CRP, ESR, and rise unnaturally of vitamin B12 level. Some other side effects are photosensitivity, and this is why when someone is treated with an antipsychotic and has sun sensitivity, the Advisory Council of Borderline Substances recommend that instead of over-the-counter self-prescription, a doctor can prescribe sun protection factor of 30 plus units for skin protection. In the same way, non-bacterial pneumonia can be produced. Some side effects are difficult to understand but show up as features that you would find biochemically in hepatitis, such as increased globulin, reduced albumin, and increased enzymes such as alkaline phosphatase, bilirubin, and also other features of inflammation. There can be neutropenia with increased susceptibility to infection. Most research document suggests that side effects of both types of antipsychotic includes akathisia, which is excessive purposeless shaking of the legs. And this is made worse with quetiapine. So now there is a list which the Joint National Formulary or Joint Formulary Committee has published in 2020. So rather than go through it, I've mentioned that the first generation oral antipsychotics are these. And the common ones that one generally uses is haloperidol, prochlorperazine, and sulpiride. Then the oral second generation antipsychotic, all of these are in popular use. What I have mentioned in this slide is, if we are talking about, say, for example, olanzapine, then the starting dose is 5 milligram once a day. It increases after a few weeks to 10 milligram, and it remains as 10 milligram for maintenance. But seeing this, quetiapine, the initial starting dose is 50 milligram, and within 2 to 3 weeks, it's increased to 400 milligram per day. But then subsequently, it can be increased further to a maximum of 800 milligram per day. So in the same way, it is important to understand how to initiate and if you know the side effects of the group, you can predict what side effects these would produce. With regard to depot injection, there are these kinds: aripiprazole, flupentixol, and then there are other kinds which are also present as a depot injection. So these are newer developments, and the side effects are similar to what the list on the other side also has. The difficulty with depot injection side effects is that once injected into the deep tissue, it is virtually impossible to remove it. But depot injection enhances reliability and also compliance, and so therefore it has no other substitute. So in practical terms, in the primary care, the aim is to treat acutely and to prevent in the adults. Less than 18 is beyond the boundary of primary care, and expert dedicated hospital advice is sought for treatment. The other aspect in primary care management is to assess for risks of suicide or deliberate self-harm. Such harms are substantial, such as when there is control hallucination, when there is thought disorder and past history of attempted suicide, when there is depression, dependence on drugs and alcohol, and when the patient is a carer for someone else, such as children or spouse. Suicidal risks are enhanced when a patient leaves the hospital after an acute psychotic episode, probably because of helplessness and lack of arrangements for follow-up in the community. When there is a high risk of suicide, although not suicidal thoughts immediately, then one should make an urgent same-day referral for mental health assessment. And crisis intervention team should be able to follow it within a day, and failing that or over the weekend, then accident and emergency will provide emergency psychiatric management. If the risks are not very high, but they are nevertheless present, then urgent specialist assessment referral is made in the primary care for the patient to be seen soon. But until seen in the primary care, one should not start antipsychotic, because such antipsychotics, if started, and even if they are not the best, withdrawal immediately can lead to neuroleptic malignant syndrome. So if the patient has been to the hospital and to the specialists with the diagnosis and treatment for a specific schizophrenia, they need to monitor this patient for 12 months. And under the shared care protocol, the primary care will offer and undertake annual review and assessment of compliance. What I have discussed is already present in, and I'm guided by this presentation. I would not click on it, and the reason is it will take me to a site which gives more enhanced information of what I have actually decided and explained. So this slide, in a nicer way with enhancement, is given via this link. So a quick mental health review by way of screening for psychosis or schizophrenia. These are the questions that you need to ask, and based on these, you can make up your mind as to whether the person has psychosis or schizophrenia. Hallucinatory voices, suspiciousness and delusion, command over which the patient has no control, apathy, bradykinesia, deterioration of functioning such as toileting and activities of daily living which the patient has been doing in the past but can't do now, additional inherent or reactive anxiety or reactive depression. Sometimes the dose adjustment can be best understood only by making a blood level of the antipsychotic given. Prolactin level, such as with clozapine, QTC changes and dysrhythmia seen on baseline ECG and comparison subsequently, assessment of comorbidities in the conventional manner, getting information on compliance from the patient and the family. In the primary care, one should ascertain whether the patient has been attending mental health clinics and other comorbidity clinics or not. When clozapine is prescribed, it is done in the hospital settings because of dangers of neutropenia and agranulocytosis. There are some additional associated triggers or risk factors: cardiovascular disease, hypertension, atrial fibrillation, valve disorders, carotid arteriopathy, congestive cardiac failure, and myocardial infarction. They make schizophrenia worse. Similarly, there are vascular comorbidities produced by other processes which can make schizophrenia and psychosis worse, such as diabetes, hyperlipidemia, sickle cell disease, antiphospholipid syndrome, and hemophilia. Ehlers-Danlos syndrome is a congenital and acquired disease of collagen tissue which leads to hypermobility, which causes certain disabilities. Marfan's multisystem disease, which is when it's a genetically transferred illness where a person has very tall height, long limbs, small jaw, and many important systems are equally affected, such as heart, lungs, liver, and so on. There are other associated triggers which can enhance the duration of schizophrenia because of disabilities such as pseudoxanthoma elasticum, where the collagenous tissues, including tendons, are calcified or have calcium deposits, which causes difficulty with functions. Von Recklinghausen's disease, obstructive sleep apnea, and in particular, fibromuscular dysplasia. Fibromuscular dysplasia is a unique condition which selectively affects certain arteries, such as carotid arteries, which become mechanically thick and narrow without any intrinsic obstruction, and renal arteries. Increasingly, awareness is being made that when there is renal pathology involved in producing secondary hypertension, that commonly it is not atherosclerosis but fibromuscular dysplasia. So how does one make clinical diagnosis? From patients and family, and when you take a history, you note time of onset, and so of course, which part was abnormal, such as hearing, speech, or paucity of movements, and a speed of development of symptoms, whether there has been a respite and the symptoms resolved, whether there is loss of consciousness, what comorbidities the patient has, and whether the patient has a past history of such comorbidities such as stroke or heart attack. What medications has the patient taken which could induce psychosis? And so when one examines the patient, it is important to assess the conscious level through Glasgow Coma Scale and the vital signs, sort of say, airway, breathing, and also cardiac functions need to be assessed. A quick neurological assessment should be made, and the government advertised symptoms should be watched out for stroke, such as face has gone down, and then, of course, arm has become weak, speech is disturbed, so it's time to call emergency services. So the same things as are relevant for TIA and stroke are also related to how one deals at the first encounter with schizophrenia. These are differential diagnoses of some of these conditions. Once again, I hope that this has been of some use to your revision. What is clear is this is not a straightforward mathematical presentation, and such as a person having stroke and the middle cerebral artery is involved in the dominant hemisphere, so you would predict what the hemispheric symptoms are likely to produce. This is where thoughts, beliefs, understanding, and expressions are affected differently, and they vary from one person to another. That is why, instead of generalizing, one should aim to diagnose the patient individually and choose appropriate selective treatment. Because of the high success rate, it is important to look out for prognostic features of schizophrenia in the prodromal phase, to check for compliance, and note and undertake risk assessments. It is sad to see that more than 12% of the patients who die because of completed suicide have had a contact with a mental health worker in the preceding week, and in the primary care clinician where they have actually seen or spoken to a health care professional in the preceding month. Thank you very much, and I wish you good luck.